When we talk about the myeloproliferative neoplasms and myelofibrosis in particular, we typically talk about a chronic condition where people have a disease but live a long time with that condition. On the other hand, we know that some of those patients progress to acute myeloid leukemia, which is defined as having more than 20% blasts in the blood and bone marrow. These are baby cells that come from the bone marrow. And then the life expectancy is very short. And we are always worried about that transformation from chronic to blastic phase to acute myeloid leukemia because of what it does to a patient, and therapies are ineffective and life is short. So in between the two, there is a phase which we call accelerated phase. This is the transition period where people are living with a disease that is usually controlled and not causing too much harm. And then the blasts in particular start to grow, and the percent of blasts in the blood and bone marrow is steadily increasing. And we have a situation where the blasts are between 10 and 20% blasts. And remember, above 20 is acute leukemia, and below 5 is normal. So we have this accelerated phase. This is the time that we should be intervening rather than waiting for patients to fully transform. And the accelerated phase disease has not been fully recognized. We only identify it based on the blast, but perhaps there are other biological factors like mutations or change in chromosomes that carry genes, or other clinical correlates like very low platelets that would indicate patients that are in transition period to acute myeloid leukemia. So there are some prognostic factors that we can utilize to address the issue. Is the patient in transition? Is it progressing? Is it in accelerated phase? And that has clinical relevance because we want to intervene sooner rather than later to stop that transformation. And so the studies are being done and medications are being used in accelerated phase patients to help them sooner rather than later. And what I was presenting is that even national guidelines, NCCN guidelines, that are now available to anybody in paper and on internet, suggest that patients that have between 10 and 20% blast should be called accelerated phase, and those about 20 blastic phase or AML, and that the therapies for these two conditions should be implemented, and they are similar. And the similarity is that we use so-called hypomethylation agents rather than strict chemotherapy. These are azacitidine and decitabine hypomethylation agents to try to lower the blast, get the patients back to chronic phase, and then intervene with the transplant to save their life. In addition, the guidelines would suggest, and in my own practice I do that adding another agent, Ruxolitinib, a JAK inhibitor, to hypomethylation agent is of value. Because remember, myelofibrosis patients have a very big spleen, very big liver, poor quality of life, loss of weight, inability to walk. That aspect of the disease problem will not be addressed with hypomethylation agents much. So azacitidine or decitabine are given for lowering the blast, and combination with ruxolitinib is highly encouraged, where ruxolitinib will counteract and improve body composition, reduce the spleen, liver, and improve patients' overall quality. So this is the point of the presentation, that accelerated phase where people are in transition exists. It has to be recognized, first of all, by percent of blast between 10 to 20, perhaps some other characteristics. And then intervention is needed at that phase to lower the blast and get patients in a better physical condition and transplant them.